Okay, so I think we are ready to start. Again, dear audience, welcome. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, European Reference Network on Rare Hematological Diseases. And so I'm very honored to welcome all of you to this 11th session of the topic on focus on von Willebrand disease for patients, organization, and healthcare professional. And as you may know, this is a joint program between the ERN-EuroBloodNet and the umbrella patients organization European Haemophilia Consortium that is represented by the EHC von Willebrand Disease Committee and also patient representative like Baiba Ziemele, who is also ePAG of the ERN-EuroBloodNet. This educational program has been also created in partnership with EURORDIS-Rare Diseases Europe and count on the support of the member of a scientific committee that consists of Professor Sophie Susen from CHU in France, Lille, Professor Jeroen Eikenboom from Leiden University Medical Center in the Netherlands, Professor Flora Peyvandi, who will be with us today from Fondazione Ospedale Maggiore Policlinico Milan in Italy. And so I'm happy now to pass the floor to my colleague Daria, who will introduce to you the patients organization umbrella I mentioned before.
Thank you so much, Mariangela. My name is Daria Camilli. I'm Education and Communication Manager at the European Haemophilia Consortium, or EHC. EHC is an international non-profit organization. We represent 48 national patient organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. We represent approximately 120,000 people diagnosed with rare bleeding conditions such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. Among them, VWD is the most common bleeding disorder, affecting up to 1% of the general population. However, it is still neglected and very often overshadowed by hemophilia. So with this program, we aim to distinguish von Willebrand disease from hemophilia, and we focus on the particularities of this bleeding disorder. In the framework of this program, we discuss very topical areas related to von Willebrand disease among patients and healthcare professionals. And we want to give visibility to the challenges of those living with this rare disease, including quality of life, access to treatment and care, medical services available in Europe, diagnosis and treatment options, and the overall patient journey through life. As Mariangela mentioned, this webinar is already 11th in our program, and we have only 2 left after this one, and we hope to see you on that one as well. And this webinar focuses on VWD in emergency room. And before we move to the webinar itself and to the introduction of the speakers, and I give the floor back to Mariangela to share with you some home rules and more details about accreditation of this program.
Thank you very much, Camilla. So we start from the positive point before arriving to the rules. So indeed, this program is accredited by Continuing Medical Education Point issued by the European Hematology Board of Accreditation. And so for requesting the credit, one session is 1 credit. You will need just to participate to the program and answer the survey that you will receive at the end of the program. It's just a satisfaction survey, but it helps us in assessing the program. And then at the end of the full program, you will know the related accreditation right and awarding you have developed. So don't worry, we will contact you. Then we arrive to the rules. So as you can see, this session is recorded because videos will be implemented in our website, YouTube, and all the learning environment of the ERN and of the EHC. And then your microphone will be muted along all the presentation, but all the questions, comment, feedback are welcome. You can write them in the chat during the presentation or at the end, or you can also raise your hand and we will unmute you for giving you the floor. Said so, maybe you are familiar with the format of this program. Indeed, in each session, we have a duo or even a trio of expert physician or nurses, psychologists, and patient representative. So today we count on a physician and a patient representative. So I'm very honored to introduce you Flora Peyvandi, who is professor of internal medicine at University of Milan, and also director of the Angelo Bianchi Bonomi Haemophilia and Thrombosis Center. She's also head of the Department of Rare Disorder at the Fondazione Ospedale Maggiore Policlinico in Milan, that consists of 15 ERNs. So Daria, do you want to introduce Sunny?
Absolutely. I want to introduce to you a patient representative for this webinar, Sunny Maini. He's an engaged patient advocate from the UK, and he's also ex-co-chair of the EHC Willebrand Disease Committee. Sunny, the floor is yours.
Thank you, everybody, for making this happen. Everyone can hear me? All good? Yeah. Okay. Brilliant. Brilliant. So my name's Sunny. Bit of a background. I've got von Willebrand's type 3 severe. So I was diagnosed when I was a little baby. My parents unfortunately saw me bleed in the cots, and then they were like, right, rush me to hospital. And they, luckily at that point, we were in the UK, and some of the ER doctors were aware of von Willebrand's, which was really, really good. So they knew that the first thing they needed to do was call the hematology department. They called the hematology department, they did the tests, and luckily they realized that I have von Willebrand's type 3. So that's like a good scenario from when it first started when I was a baby. So you can see a positive light that actually there is some hope, and there are some people who are willing to always learn about von Willebrand's and know the right practices. But that's not always the case with von Willebrand's. So a lot of people, as we all know haemophilia. Not many, I would say, surgeons or A&E staff know about von Willebrand's, let alone the people at the beginning. So it might be different in other countries, but in the United Kingdom, if you're ill and you're seriously bleeding, you go to a receptionist, and the receptionist takes your details down, and then she tells you to sit down. Then you have to wait for X amount of time to see a nurse, and then the nurse will then do tests, blood tests, and then they will get the doctor to come and see you. Now, you can see that there's many different gatekeepers there, from the receptionist to the nurse to the doctors to then the surgeons potentially, who will be operating on you. Most memorable experience recently is roughly, I think it was in 2023. I had a pain in my stomach. I've got my own business. I was presenting to board of directors, and I went, ow, my stomach hurt. I was like, oh my God, this is painful. And I just ignored it. And I just thought it would go away. And unfortunately, it became so terrible, the pain and excruciating, that I had no choice but to go to accident and emergency. Now, I'm a typical man. I think I'm strong. I should have gone a long time ago, to be completely utterly honest. But when I went into the emergency area and I spoke to the receptionist and I explained to her, I've got von Willebrand's, here's my bleeding disorder card, we need to move this forward. At this point, I must say that the hospital I went to was not my hospital at that time. So if it was the hospital of my choice, I would have rang up my hematology department, said I'm coming in, A&E, and I would then be seen by them, and then they would be there throughout the whole process. This was a completely different hospital who weren't fully aware of who I was. As I went to the receptionist and explained my symptoms to the receptionist, she wasn't really aware of von Willebrand, and she didn't really care. Bless her, because how many patients has she heard stories of wanting to get seen quicker and faster and faster? And ultimately, I was in the waiting room for 3 hours before I even was seen by a nurse. Once I saw the nurse, the good thing about the nurse is she was very interested. She's heard a little snippet about von Willebrand, but she didn't know what it was. So while I'm in pain, I have to explain to her what von Willebrand is. And then by that time, while we're waiting for the tests, the actual A&E doctors, unfortunately, were not very aware of von Willebrand. Now, one of the key things as a von Willebrand patient is self-advocacy. I'm a massive believer in, if you have a disorder, a disease, you should know about it and what to do in that situation. And one of the tips that I was always given was, regardless of when you're in ER, try and call the switchboard and speak to the hematology department straight away. Or if you've got your doctor's number, call your doctor. I had my previous doctor, and try and carry the importance of understanding and people who don't understand von Willebrand and educating them up to a point to call a hematologist. Ultimately, my situation was not the best, to be honest. So it took me 13, 14 hours to be seen. By then, I had a bit of internal bleeding, and then it got operated by the surgeons. And just before they put me to sleep, I said, "Do you know about von Willebrand?" to the surgeon. And he said, "I've heard of it." And then I was knocked out. Right as he just said, I've heard of it, but he wasn't aware of it. Look, the point of it is, the one good thing was the hematology department did speak to him up to a point.
Signal lost.
But the end of the view is, while von Willebrand is extremely more common than what people think, the problem is people like Flora are amazing. They're there, and Maggiore and ERN, we're trying to spread the word, and EHC is trying to spread the word, raise advocacy. But the problem is, it all comes down to education. And unfortunately, not all surgeons are educated about von Willebrand. Not all doctors are, not all nurses are. But there are some who are advocating it proactively. So when I was speaking to the surgeons afterwards, it was interesting, because a lot of the surgeons were interested in finding out more about von Willebrand after that period. After that period, they wanted to know more about von Willebrand. They wanted to understand what it was, not just what your treatment plan is, but actually what is the actual impact of it in a scenario of surgery. Now, look, there's been many, many occasions. I'm a typical boy. I like living on the edge, and I have been in ER, A&E many, many years of my life. And one of the struggles that I've always had is not being listened to. So even though I give you the facts, even though I'm telling you to speak to the hematology team, you're not taking this bleeding disorder serious. And this is it doesn't happen all the time, but it happens too many times. And the problem is, ultimately, me as a patient, I have a part in educating myself about von Willebrand. And I think, if I don't educate myself, how can I educate others or the people younger than me? And ultimately, you can't go into a situation where you expect people to know about von Willebrand. Unfortunately, it's just not the case. But there are enough people who are there to help in those situations, if that makes sense. So for me, as a patient and advocate of education, for me is understanding my von Willebrand, what I have. And these seminars are brilliant because it goes through all the different levels and all the different areas of life, from pregnancy to growing older to age to being in the surgery room. But you know, what is encouraging generally, and leaving it on a positive note, is that there are things like this. There is education happening, and before anything, you know, in the ER situation, it is educating yourself up to the point that you can stand up for yourself and say, no, I've got von Willebrand's, this needs to be taken seriously. Go speak to the hematologist, and pursuing that. Don't just listen and be shunned away by people. Actually stick up for yourself so you get the best treatment, and ultimately spread the word. And that's my story, a bit of positive, a bit of negative, and yeah, there's a lot of room to grow in this area. Cool.
Thank you, Sani. And I can confirm that back to 2023, when you were still with the committee, I remember that story happening to you. And that's also when we decided that we needed to have this specific webinar on VWD in emergency room. And of course, the choice for the speaker from the patients was obvious that it would be Sani, and here we are. So yes, unfortunately, that negative experience brought us here. So yeah, Flora, the floor is yours.
Thank you very much, and good afternoon, good evening to all of you. I have to say this presentation with Sani was really important and touching, because as a physician, I understand even more now how important it is to hear the voice of the persons with bleeding disorder, any type of bleeding disorder, and understanding how much awareness and advocacy is important. And I want to thank EuroBloodNet and EHC for this combined type of platform to bringing what needs to be done in terms of education. So I'm trying to share the slides that I have prepared for you, and I hope you can see them. Yeah, here we try to put down what are the learning points that I want to focus in the few minutes with you on what is von Willebrand factor and its role in hemostasis, and what are the first aid, because Sani explained clearly when he was going to a hospital where he was not really known to the group of nurses, how difficult it was. But can you imagine if it's an emergency situation and he cannot explain, and the patient could not explain what is the situation, how this type of emergency work should work, and who should be involved, and what type of procedure should be there. Challenging obtaining the pain relief medication, and also difficulties in assessing clotting factors, identification of the patient with von Willebrand disease in emergency setting, as we were saying before, and the medical ID and medical record and their importance, and how we have to use the guidelines that are already available for the hematologists, and 24-hour monitoring patient with von Willebrand in the hospital after trauma. These are all points that you need to consider when you have a patient with a bleeding disorder, and on von Willebrand even more, because this disease is less known for also hematologists, and lots of awareness is necessary for that. We have already started from the previous session about what is von Willebrand factor. This is the largest and the biggest glycoprotein that is circulating in the blood, and is a loosely coiled protein complex under basal condition of the very low shear stress. And as you can see here, when von Willebrand factor is activated is when there is a vascular injury, and this vascular injury could be for any reason, infection or trauma or whatever situation, is getting the collagen on the endothelial cells is getting exposed, and the conformation of von Willebrand factor is getting changed, and then unfolding of von Willebrand factor is making facility to the start of the primary hemostasis. Binding site of von Willebrand factor is starting to activate also the role of ADAMS13 because it's binding to the platelet, and ADAMS13 should cleave von Willebrand factor. So this orchestra of movement and change really is very important. And then you need the fibrin plug to start to work and making a stabilization of the primary clot that has been formed with von Willebrand factor and platelet. There is also a very important other factor, which is factor 8, and you know it very well from hemophilia. And factor 8 and von Willebrand factor, they're always going together. And that's the reason why when we are treating a patient with von Willebrand factor, we always have to understand what is the situation with factor 8, because von Willebrand factor has a very important role in primary hemostasis, and it's binding to platelet at the beginning of the formation of the clot. But then you need factor 8 to be there and to make a stabilization of this clot. And that's the reason why a physician should understand real diagnosis, the level of von Willebrand factor activity, and also factor 8. Now, in terms of the first aid in emergency assistance, if, for example, the patient has an accident with von Willebrand factor, the first point is the emergency point is evaluation of the signs if there is any shock, and how is the blood pressure of the patient, and if the patient is conscious, and then starting immediately to get the information. If the patient is conscious, of course, can give the information to the physician or to the ambulance, but if it's not, it's very important this ID card or whatever instrument the patient could have. And then the most important point is to understand where this patient is having all the clinical information and the storage of the clinical information. Is it a hub spoke or is it a spoke center? And if the patient's information is not clear, it should be the contact between the ambulance and the first and the closest ER hospital and immediately to the hub center. So understanding the diagnosis and understanding what is the level of von Willebrand factor and the type of von Willebrand disorders is extremely important. But first of all, we need to stabilize the patient. We need to make a vital sign, understanding the heart rate, blood pressure, and everything that in the emergency we are treating, understanding the coagulation. Of course, if these coagulation tests are already for the reason of von Willebrand factor alterated, we need to understand what type of von Willebrand factor diagnosis is there. But again, stabilization is important. Then management of hemostasis, and how the management of hemostasis, treat the patient as soon as possible and getting in touch, and in the transfer of the patient to the hospital, treat the bleeding event and bringing to the closest hospital. Now, if the patient is getting to the hospital, but for example, there is a head trauma and need a major surgery, what you need to do? You need to make sure that you are bringing the level of factor 8 and von Willebrand factor, both of them, over 50 by sure, but if it's a big surgery like a heart surgery, you want to make sure that it's even over 100. But at least for 3 days, you want to keep the levels over the level that I mentioned. And what you have available as a product is very important. The hospital where the patient is bringing, for example, for us, we are in Milan, a hub center. We are getting a lot of call during the 24 hours emergency call for the small hospital that they have a patient over there, but they don't have a accurate drug for the treatment of von Willebrand. We have to make sure if the patient could be transferred to our hospital, or if it's not, we are even sometimes sending the concentrate to this hospital, stabilizing the patient, and then transferring the patient to our hospital. So what we have available, we have desmopressin. Usually you're not going to use the desmopressin if you do not know how is the response of the patient and the trial has not been done in the patient. But if the patient is stabilized, you can, of course, use the desmopressin, not for type 3, not for type 2B, and for type 1 and some of the type 2. And you can use von Willebrand factor alone, could be plasma-derived or recombinant von Willebrand factor, but you have to make sure that there is enough factor VIII to make the hemostasis. And if you have a patient with type 3 von Willebrand disorders and you are in emergency situation, you have to have enough time, at least a couple of hours or something, if you want to use the concentrate which is containing only von Willebrand factor. If you do not have time, then you have to get a complex, or you have to make an injection of factor VIII and von Willebrand factor together, or you can separate it. But you have to make sure there is enough of both of the factors. As I said, you have to make sure that for a few days, 3 days at least after major surgery, you have the levels over 50%. And also you have to understand that every factor VIII unit is increasing the level of factor VIII by 2%. And for von Willebrand factor, this is a little bit less, about 1.4% for each international unit per kg. Now, what are the type of the treatment that I can do? I already said that. You have to be careful not using desmopressin in type 2B, because sometimes you can have thrombocytopenia with the low number of platelets. And for example, in pregnancy and women who are pregnant, you have to be careful. In type 1, you can use it if you know how much is the increased level after the injection of the desmopressin. And usually you're waiting for seeing 3 to 5 times more after the injection, about 15 minutes, 30 minutes. In type 3, you're not using, especially in emergency, and you're not using because desmopressin would not be a response in type 3. And in emergency setting, usually I do not use it if I don't know what would be the response of the patients. And in type 3, there would be a lack of efficacy, and type 2 is contraindicated. You're not using in cardiovascular disorder also. And there are a bunch of different type of product that you can use in case of emergency. For example, plasma-derived products, you have several types, and you know exactly what are the type of the purification, what is the company that is producing this product, and what are the level of the activity of von Willebrand factor and the level of factor VIII. And you can measure more or less the amount of the factor you need for the treatment of the factor. So when this table was prepared, there was not yet recombinant von Willebrand factor available, but now you have also recombinant von Willebrand factor, which is a good source of activity for von Willebrand factor with the ultra-large von Willebrand factor, and then good level for the primary hemostasis. And as a single von Willebrand factor, you have plasma-derived product, which is vilfactin, and recombinant factor, as I explained. Otherwise, you have several factors that you can, products that you can use, and they are having both factor VIII and von Willebrand factor. As I explained before, if you are using vilfactin or recombinant von Willebrand factor, you need to make sure the patient could make a recovery and needs a couple of hours. And if you are in emergency and you need a speedy increase of von Willebrand factor, you have to inject also factor VIII to the patient. So for minor surgery and the minor bleeding, there is the guidelines that is with a conditional recommendation is reporting that increasing von Willebrand factor to more than 50% is possible with this desmopressin or with concentrates that I showed you, with the addition of tranexamic acid, which I think is a very important instrument as an antifibrinolytic products. And giving tranexamic acid alone could be done in von Willebrand type 1 when the level of the factors is more than 30% and with a mild bleeding phenotype. So I think it's very important the amount of the bleeding of your patient, and you do decide whether you want to add antifibrinolytic or to the concentrate, or only antifibrinolytic could be enough. So the remarks that is coming in this guideline, individualized therapy plan, are very important for the patient. And usually when von Willebrand factor activities increase to more than 50% by any therapy and addition of tranexamic acid, you have, of course, for minor surgery, you might do not need it. For major surgery, you can need the tranexamic acid. In type 1 von Willebrand disorder, desmopressin or von Willebrand factor or the concentrate could be used with or without the additional of tranexamic acid. In type 2 von Willebrand, again, you can use von Willebrand factor or the complex with the addition of tranexamic acid. Please pay attention to in the situation, as I explained before, when you have type 2B, do not use the desmopressin. And in type 3, again, do not use the desmopressin and use only the concentrate. For those patients that they are at a high risk of thrombosis, you might want to avoid the combination of increased amount of von Willebrand factor and especially factor 8 over 150% and also antifibrinolytic, because you are increasing the risk of thrombosis. In some of the procedure like dental procedure, you could use the local hemostatic measure or actually antifibrinolytic product is working very well. And for major surgery, as I mentioned before, please pay attention to keep the levels of both factor 8 and von Willebrand factor over 50% for at least 3 days. And there is, again, there is a suggestion in the guideline that has been published by the 4 organizations, ISTH, American Society of Hematology, World Federation of Hemophilia, that you do not need to go only with factor 8, but consider also the level of von Willebrand factor. So the information and the duration of the intervention could be very, very different from one surgery to the other one, and also from one bleeding episode and the severity of the condition that the patient is coming to the emergency. The specific target level should be done again on the individualized base of the patient, the type of the procedure and the type of the history of the bleeding, and also availability of the product and the testing that you are having. And this was the guideline I was mentioning, American Society of Hematology, ISTH, National Hemophilia Foundation, and World Federation of Hemophilia in 2021. And if you want to have more detailed information, you can go with this guideline and have a look. I'm going to bring 3 cases for you at the end of my presentation. The first case is a woman of 20 years, a young lady with type 1 von Willebrand disorder and group 0. And this lady was presenting with frequent menorrhagia episode, 28% of factor 8, 26% of von Willebrand antigen level, and resuscitating activity level of von Willebrand factor, it was 25%. This is very much matchable with type 1 von Willebrand disorders. So the family history of this woman was her mom has also a history of prolonged bleeding after minor wound and no significant bleeding after surgery or delivery. It was a significant PBAC score, 435, which was clearly showing the importance of menorrhagia, and also this patient had a low level of hemoglobin with the ferritin, and we decided to make the hormonal treatment, estrogen progestin treatment, and the PBAC was really improved after the treatment with estroprogesterone treatment. And when there was an issue of menorrhagia, we were actually using the desmopressin because there was a very good response. You can see before the injection of desmopressin, the levels were, as I told you, partial deficiency, but after 1 hour, 2 hours, and 4 hours, you can see there was a significant 10 times almost increased level of the factor. So in this case, it's clear you do not need to use the complex of von Willebrand factor 8 and factor 8, and the patient is responding very well. And of course, depends on how many times and how frequently you need to infuse the patient with DDAVP, because that response could not be kept for more than 2-3 times. So here I would say there is a very good response and is a successful treatment using DDAVP. For second patient, it was a male of 37 years with type 2M and low von Willebrand factors, about 14% of antigen and 6% of RICOF. This patient was unfortunate because it was also low level of factor 8, and level of factor 8, it was 33%. And you can see that, unfortunately, the patient had a head trauma. It was 80 kilo. This car accident with multiple fracture and also skull fracture, it was a heavy situation in emergency room. The patient has been, we have been called by ER physician, and immediately we started the treatment with plasma-derived concentrate containing factor 8 and von Willebrand factor. And you can see that more or less we use about more than 50 international units of products. And since the patient was starting with 30% of factor 8, we were expecting to have more than 100 because we were having a head trauma. So then once that infusion has been done, it was a very good increased level of factor 8 and von Willebrand factor. And then for the surgical reduction, then we added 2,000 units for the fracture, and it was very successful and everything went very well. The third patient, it was a woman of 34 years in pregnancy affected with type 2 von Willebrand disorders. And you can see that level of factor 8, it was 89%, antigen level 80% with a RICOF of 5%. And the patient was 66 kilo. With the previous cesarean delivery in emergency, and you can see that how the choice of the treatment and the type of the treatment was important. So the patient was with 89%, and of course during the pregnancy the level of factor is increasing also. You remember we cannot treat this situation with desmopressin and with DDAVP, and we have decided to use only the pure factor. That time was available only plasma-derived product. We used vilfactin and also tranexamic acid without any complication. And in the indication for the delivery was the usage of 4,500. And again, if you see more or less, we have used 70 international units, 30 minutes before cesarean, and epidural anesthesia. And again, we added 1,000 milligram of tranexamic acid 30-60 minutes before cesarean or epidural anesthesia, and everything went very well, very successful, and the delivery has been performed. So the take-home message that I want to bring is very important, ensuring the timely access to the medication and developing a good strategy to prevent the delays in providing first, access to the product, pain relief, and the clotting factor. Prioritization of the early bleeding management. And this is very important because every minutes of the delay could have the consequences for the patient. So that needs a clear procedure. What we have done in region of Lombardy, it was to make a clear procedure for the patient if is after trauma, for example, on the road is happening something, car accident, we have a procedure over there. Once the patient is coming to the hospital, we have a clear procedure, what should be done. And also when the patient is transferred to a ward, how the continuity of the treatment should be done. And I think that type of procedure should be available in the future. Making a facilitation of von Willebrand infection identification in the emergency is very important. So I think computing the resources like patient registry IDs, electronic or paper medical record for helping the healthcare providers for recognition of von Willebrand patient promptly is a key message that we need to work on it. Engaging hematologists, expertise effectively, and also for nurses, and also the rest of the group of the emergency might not know about the bleeding and the emergency and importance of how the patient with clotting disorder should be treated. I think education, as Sonia was mentioning, is very important. Clear protocols, including a specific situation that require the involvement and appropriate steps to engage them, and also implementation of post-trauma observation protocol, adopting a 24-hour hospital monitoring policy for von Willebrand patient after trauma, if there is head injury, and ensuring the delayed bleeding is very important and should be very, very clearly detected and treated as soon as possible. And with this one, I want to thank all of you that were following, and also thanking again all the actors that are working together, EHC, EuroBloodNet, and all the groups and patients organizations that are trying to make this feasible in the future. Thank you very much. And I'm happy to get any questions.
Thank you so much, Flora, for this clear presentation. Thank you so much.
You're welcome.
Okay.
Dear participants, do you have any questions? You can also raise your hand because we haven't received any questions in the chat. So it is possible to raise your hand and just speak like this, if you wish. Yes, William. You're muted, yes. You cannot unmute. Then I cannot read your lips. I mean, I can only for this. So if you can
now you should be able to unmute.
Yep,
Yes.
that's great. Sorry, I was saying I can't unmute. I want to thank everyone for putting on this session tonight, because I think what we're talking about is very important in regards to bleeding disorder care in the emergency department. And I think it's important to talk about because it's something that is often done so badly. And certainly as a patient, I related to a lot of things that Sonny described in terms of barriers that patients can face when trying to access emergency care, being understood, getting access to hematology expertise, non-specialists' willingness to prescribe factor and factor concentrates. So there are a lot of barriers, and Flora's talk was excellent as well. The guidelines on what we need to do in these cases are very, very clear. But as you said in your concluding comments, the big issue is having protocols and systems that actually deliver these guidelines. And so I wanted to ask, both from the patient perspective to Sunny, but also from the clinician perspective to Flora, what specific procedures and protocols can be put in place to allow timely access to treatment? And can you give any examples of how these were implemented and the impact that they had on emergency care?
Thank you. Thanks for this great question. And the model that we tried to use it was a hub and spoke model, and trying to involve the Society of Emergency Medicine. We are not yet 100% successful on that, but what we are trying to, what we are actually successful that in the hub center, all products should be available. In the spoke centers, based on the number of the patient, there are some of the products available. And if there are some of the products are not available, we try in few hours to let them have that product. So that is the system they are trying to work. And in the ambulances, trying to bring them, making a awareness about this patient is differing from the other patient, and in 30 minutes they have to be treated as soon as possible with a concentrate, and trying to make them have some kit of factor 8 in the future and von Willebrand factor or the complex. It might not be the treatment that patient usually have, but at least for the emergency you can treat them with these products. So I think actually this is something I think EHAD, EHC, and all the organization at the European level should come up with the procedures, with the standard procedures, and should be applied for all the European countries in a similar way.
I think in an
Thank you.
ideal, thank you, Flora.
Oh, sorry.
In an ideal world, William, we do have VWD guidelines, and I'd love everybody to know it. And we came out in 2021. It was an amazing thing, right? It was an amazing thing. Let me put my video on. It was an amazing thing, and it was meant to be game changing, and it just kind of went away like a balloon, basically. And unfortunately, I don't like, we've got brilliant people like Flora, and we're doing some brilliant work with EHC, and there are things people are doing, but ultimately as a von Willebrand's community, we are not as, how can I say, as vocal as we should be. There is a lot of disparity, there is a lot of subdivision, and unfortunately that in itself means that the overall awareness, like in any business, will never get to where it needs to be until that changes, if that makes sense. And I think once that changes, and with these kind of seminars, we've got, as patients, I remember when we set this up, and we were looking at the different streams when I was the chair of VWD for EHC, is one of the key things we wanted to do was make sure that it's all well and good going to conferences, it's all well and good going for drinks with your VWD patients, but we wanted to get the clinicians involved to have both perspectives. But ultimately, it comes back to what I said, Nelson Mandela, education is the most powerful weapon you have. You've got to educate yourself. And there are things out there, and we are blessed, we have WFH, we have EHC, we have EHAD, ISTH. There's loads of stuff that you can take home. There is VWD guidelines. Whether they listen to you or not, that's a different ballgame.
Yeah, Tony, you are very correct to what you are saying. First of all, I think as a physician, we need to make sure that the messages are clear, because is when things are getting complicated, the people are in trouble to understand what is happening. If you want to make the awareness, the messages should be clear and few of them. Second things, where for the emergency is becoming more difficult because we need to involve the Society of Emergency Medicine, and also bringing, you know, the people who are taking at your city, the emergency ambulances and everything. That was the most difficult part. Still, we are working at our region on that. And I think that part of awareness means the collaboration between the two societies, emergency medicine, hematology. And that's the kind of the work that we need to work in the future.
Thank you so much. There is a lot happening in the comments.
Yeah, I was trying to respond. Yeah, there was one question on that.
We will read it because it's important for the recording as well, because the comments will not be available. Mariangela, do you want to take it?
Yes, thank you. Thank you very much. So I can take the first one. Thank you for the great presentation. Is there a contraindication for epidural anesthesia in a type 2B patients?
No,
sometimes there is.
Yeah, sorry, because this is a very important point, because in patient with type 2B, sometimes the number of platelets are low and the physician do not feel comfortable. I think if the levels of factor VIII and von Willebrand factor is over 50%, at least 50%, I would prefer even 100%, to be very honest. And I think in the guidelines is reported, so we can make sure the woman is a normal, has a normal hemostasis. And on platelet, at least 50,000, I think, should be confirmed on the CBC, and then you can make this type of procedure before the delivery.
Thank you so much. I will tackle the other questions. So there is one for Professor Peyvandi. What factor levels should be obtained in prophylaxis, and what can we do so that the colleagues in the emergency room take patients more into account? And pretty much the same question to Sani. From his perspective, what should be, like, what the patients should do to be recognized in the emergency room?
Okay, depends on what type of the patient is there, because you remember I showed 3 cases. One was type 1 and it was a mild deficiency, and the patient we knew that was responding actually to the desmopressin, and you can treat that case with the desmopressin. But if the patient, for example, is unconscious, you don't know, at least I think you have to treat this patient with 50 unit international of the complex of factor VIII and von Willebrand factor, because at least you are sure that more or less you are increasing the level to 100. Of course, the level of the factors, the residual amount, is very important to understand with which level we are starting the treatment. So I think the patient should know that for minimum hemostasis, you need 30%. For the maximum, you need 100, 120. So it's very easy. If you have 0% of the factor, and we said 1 unit of factor VIII is increasing by twice, so you need 50 international units to get it to 100. But for factor from Rikov, you need a little bit more. So that's the more or less the calculation. If you are 50 kilo or you are 70 kilo and you need to increase it about, for example, from 0% to 100%, so that means your weight is 70 kilo, you need at least to have 3,500. So 50 international unit, multiply it to your weight. So that's something the hematologist should know. But again, depends on what is the level of factor VIII and activity of von Willebrand factor, and what is the amount of the bleeding and severity of the bleeding, and which level you want to keep. What you have to ask them to be in touch with your reference center physicians and treat yourself as soon as possible.
Thank you. Sunny, do you want to tackle the other question?
Yeah, I think if you want a systematic change, you have a part to play in it. Okay. So what do I mean? What do I mean by that? Is, yes, you can, there's a couple of things you can do. You can encourage your haemophilia treatment center to maybe set up a training thing with the ER team or the ambulance team and get them to do it. Doctors will listen to doctors, and inner medical people will listen to inner medical people. Then a patient chucking things at people and saying, you don't know what you're talking about. That's not probably the best thing to do. The best thing to do is speak to a hematologist, talk about a few issues that you've come across, find out that there's any spaces. And I don't think there's any medical professional that I have seen who's not willing to listen, change, or adapt. And if I've not come across one. That's the first thing to do. The second thing you can do as a von Willebrand's patient, depending on what country you live in England, we have bleeding disorder cards. Take your bleeding disorder card with you. That's number one. I know other countries have got that. I was speaking to people about education. One of the things you can do is to print or save guidelines and give it to the emergency team, or speak to them and self-advocate that way. There's plenty of material out there that you can just use and give it to them and set up a meeting with specific people, i.e. the admin. People forget that the admin team are actually the glue sometimes. They've actually got a very, very big job in the sense that they can get things done. And actually, an example is, I had an issue, somebody was speaking to me, they had a problem with a particular surgery. It was a GP general practice surgery. And I said, well, why don't you print some notes about von Willebrand? Because a lot of people aren't aware of von Willebrand and the impact it has, and then the actual psychological impact. And they gave them loads of leaflets. The general practitioner read it, called the person back up, and they set up a meeting with 6 of them, 6 doctors and nurses. That all happened because one person gave somebody information, explained their story, wasn't scared of explaining their story, and that's how a systematic change happened in that particular practice. So there are things that you can do. The overall grand scheme, there's a lot of work to be done. A lot of work to be done.
That's a very good plan. Please come to Milan, work with us with that.
Thank you, Sunny. I have a question in the chat from Joe Tronter, the EHC VWD Committee co-chair since the foundation of this committee. So now we talked about the perspective of the patient, like what patients can do, but what Joe stresses that sometimes, very often, I would say, the main barriers to effective care emergency medicine in hospitals is lack of education and awareness from clinicians and nurses. So the question is how speakers suggest we approach these barriers when we find ourselves in an emergency situations as patients.
Yeah, that's again as Sunny was mentioning, is making a plan. I think your hemophilia treatment center need to collaborate with the ER and making a kind of plan in terms of education, not only on physician, but also on nurses. For example, every year we try to understand, because of the change of the product, especially for hemophilia. For von Willebrand, the change is not so fast. But for hemophilia, for example, what we do, we are trying to train our nurses every year of what is happening, what are the type of the product, how is the responses of the product, because they don't know really how things are moving. I think this is a responsibility of Hemophilia Treatment Center to work with the emergency and trying to make a protocol together and making a good collaboration on both physician and nurses.
Thank you very much. So I see there are another question. In the meanwhile, to see if some other arrives, I will recall the last 2 sessions. Those will be dedicated to well-being, quality of life, and psychology. So indeed, we are going to talk in the next session that will be in the 13th of February about emotional trauma. And the last one will be about the topic of improving the quality of life for people living with von Willebrand disease, and it will be on the 20th of March, the last one. So I hope to see all of you in the last two sessions. So I see no other question arriving. So I would like to thank a lot the two speakers that were with us tonight. So thank you very much, Sunny, for having showed the lived experience from a patient point of view on this very critical topic of emergency. And also thank you very much, Flora, for having shared your expertise with us. And I know today it has been a very, very important topic. And lastly, but not the least, I really want to thank Daria and all the EHC for their huge support, and it's really a pleasure to collaborate in this project with all of you. Thank you very much.
Thank you to all of you for the organization.
Thank you, everyone.
All right, thank you all. Thank you all.
Thank
Catch you
you.
later.
Bye, Sunny.
Thank you. Have a nice evening. Bye bye.